I wanted to mention, as far as my disclosure, I have received research support from National Institute of Mental Health. My research support from Pfizer includes that they're currently providing medication for an SSRI study that we're conducting. My support from Shire had been for participation in the various clinical trials that they had conducted for Intunif, for Adderall XR, and I have served on an annual basis. They have an advisory board meeting, and I've just been asked to also participate in some advisory boards that they're trying to convene on adolescent and ADHD treatment and cultural implications of ADHD. And in the past, I have been on an advisory board for atomoxetine for Lilly. I also wanted to briefly mention that I had some help for the literature review. We have a visiting scholar from South Korea at the University of Florida, and Dr. Kim had gotten busy with our lit review here. What I wanted to do this morning was we know what our charge is, but we need to put this into a context. So I also wanted to provide some context to our charge. I wanted to review some of the common quality of care concerns that we see in Medicaid populations that receive ADHD treatment, and take you on a very brief detour on a concept of family partnered care that I think can help with some of the problems that we run into with prescription management for ADHD. And then look at the evidence-based ADHD psychopharmacology, and very briefly just touch on what I consider the old established ones, and spend some more time on what's new since this last review of the guidelines, which is guanfacine XR. Some brief reflections on aggression in context of ADHD, and putting this in connection with the ACAP ADHD treatment guidelines. But the entire time I'm going to also try to keep our eye on the goal here, like the little cat knows for sure it wants to have the goldfish. And what we want to do is really think about, do we need to update the treatment guidelines, and what that we're covering this morning may inform that decision. The quality of care concerns in ADHD treatment range a gamut. There is definite evidence of poor treatment engagement and high dropout rates. So when we have medications that have potentially nice effect sizes, these effect sizes can actually only be implemented if patients continue to stay engaged in the treatment. So that's one really big problem area. The other one is there is poor safety monitoring. Like in a California study of public mental health clinics, less than a third of the charts that were reviewed in this project actually indicated any vital signs or lab study monitoring. So there's problems at that level. You know, the patients that are engaged in the families, they may not get the level of quality of care. We know there are high rates of polypharmacy, and in particular high rates of antipsychotic use. So in a very recent paper from Dr. Constantine and his group here, they looked at the Medicaid recipients of antipsychotic meds, and they found that among the 6 to 12-year-olds, as far as the medical diagnosis attributed to that antipsychotic use, there was 17% had diagnoses of psychosis or bipolar, but 45% of these children, their diagnosis was ADHD. So I think we know we're needing to keep that in mind when we look at practice guidelines. I mentioned a brief detour here, and I really am not going to go into much detail here, but I think we have to stay aware that medication treatment can only occur if there is a relationship between a treatment provider and a family. And ideally, we want to have rapport. We want to be able to partner with families, and then based on that knowledge, provide them with some targeted educational resources, because they need to know things in order to implement that treatment regimen. We need to be able to offer empirically supported psychosocial therapies, even for ADHD, and then use evidence-based medication strategies. in the context of a partnered planning. And where I think the rubber hits the road here is that in Medicaid-covered populations, you basically face an even more extreme time pressure, and packaging all of that into the context of the medication visits can be really daunting. To put this into a context here, there are some pieces to that I think even in a busy practice environment we want to be aware of. During the period of engagement, I think it's very important to keep in mind that the person who is with you may not be the person who's the decision maker. You know, so if you tell a mother your child is going to be on ADHD pills, but actually there's a father who is against that, or a grandmother who has to say about meds, it's just not smart to not ask about that. You know, the few minutes that takes may be the few minutes that they're not going to drop out of care when they come home and they say, you know, just no way, that's not going to be happening. The other thing is we're so pressed for time that listening to their story feels like we don't have time to hear all that. I know ADHD, you know, let me tell you something. But actually we do need to know what the family really feels they need and want and what their preferences are. Because if their preferences go in a direction different from what we're offering, you know, if they're polite, they're going to listen and nod and then go, and the first side effect happens, then it's not really going to continue to work. I'm not going to go more deeply into the education part, but I wanted to draw your attention to this. Assessing treatment willingness, and then also being able to handle if there is a disagreement that maybe you can't have that prescription right at the first visit. Again, I know that's very tough to implement in busy settings, but just keep in mind the deal with the dropout rates. It nearly looks to me like we can't afford to not do something different here. And then in terms of partnered implementation and monitoring, you know, we're trying to do a good job using standardized scales to capture ADHD symptoms, but that may really not be what the family uses as a measuring stick. You know, to them it may be, does the kid continue to lose their sneakers that they have been paying a bunch of money for, you know, or some other practical things, and finding out what are some of the things that really matter. Put that onto the treatment plan to make it theirs. And very importantly, anticipating side effects and adherence barriers. I mean, we know so much about what is likely to occur. If we feel like we can't take the time to reasonably talk about that, then our schedule is going to be open because they're going to no-show for the next appointment. This is just in case you like to have material for later. I wasn't going to go over that, but it's educational resources. We're not talking about behavior therapy here today. We're talking about meds, but we keep in mind that the med guidelines also say they need to be implemented in the context of effective strategies. And we have kind of this interesting dilemma that we feel like, okay, the MTA told us it doesn't really matter. But then when you look at reviews, for example, Pelham's review, there are effects and positive effects from behavioral interventions, and families prefer them. So I think we just need to keep in mind, and there are specific things. The behavioral parent training would be one specific direction to go. School-based ADHD interventions we would have much less impact on unless you are able to be in the schools or work with the schools. And then the other one for preschoolers, there is now a nice emerging literature on specific interventions like PCIT or teacher interaction therapy, the Incredible Years program, or Triple P. So psychosocial for the really young children, where we potentially have a preventive if we do it. That takes more than just like sitting down with the parent and saying, you know, put them in the timeout chair. Those are specific things that would have to be learned and then offered. So on a really fast pace, so those are, I think, some contextual issues here for then thinking about evidence-based ADHD psychopharmacology. And we're all just really familiar with this. What do we have that's FDA approved? We have the